Well, good afternoon, and thank you for joining us. You've landed at the CAF COVID Weekly Roundup. My name is Jason Belden. I'm the Director of Emergency Preparedness, and I'm going to take you through a bunch of updates this week, and we'll have a correction on our NHSN information. Department did a 180 since last week, so we've got some big changes on the NHSN reporting. If you tuned in last week, we're going to really contradict a lot of what we said last week, and so stay tuned for that. We'll cover the Cal-OSHA emergency standards, as well as changes to the CDC travel recommendations. So we got a bunch of stuff to cover. Patty's not going to be able to join us. Patty's meeting with the department this afternoon at the same time, so she won't be able to join us. And I will attempt to answer all the regulatory questions in the chat box at the end of the call. So with that, let's get started. As always, you can find information on the caf.org/resources/coronavirus to find a lot of the AFLs and regulatory guides that have been issued. Certainly, you can go onto the CDPH website and download some of that stuff. We just kind of collect them from multiple agencies and put them in one spot. As an introduction, the speakers and opinions are expressed on their own on this webinar. They may not reflect CAF's official position. These webinars are brought to you as a part of a grant-funded program through California Department of Public Health and Los Angeles County EMS Agency. I have no personal financial conflicts, and I will be the only speaker on this webinar today. The intent of the webinars is to give you a situational report of changes to the response for coronavirus forecasting, where we can identify things that are likely to change. Sometimes we get that wrong, and I apologize. As well as highlight best practices when we can identify those. So let's hop right into it. I know many of you guys have seen there's been a number of AFLs that have been released. Not all of them apply to skilled nursing facilities or intermediate care facilities. The ones that do apply, I've carved out here, and we're going to cover the visitation one in a second. But these ones are real quick updates. In terms of AFL 2032.3, this is just the removal of the waivers. It puts a date on the waivers of when they're going to expire. Those waivers are for space conversions and things like that. This waiver is already in effect. This just extends it until July 17th. If you need flexibility or a waiver, you can still utilize the program flex process either through the 5000A or 5000 process. The 5000A needs to go to the CHCQ headquarters, and the 5000, I believe, goes directly to your district office. And so you can still, even after this expires, if you need program flexibility for space conversion, especially as we talk about indoor space in terms of visitation or communal activities and things like that, where you need to change what you use that space for, that flexibility may need to extend past July 17th. So if you're going to utilize those kind of spaces, just know that you'll have to submit a program flex to be able to do that after the July 17th. In terms of AFL 2117, this is just an explanation that the Concentra contract for fit testing services that CDPH had employed are going to expire on June 30th of 2021. So if you're going to utilize that service, you need to do that prior to that date. After that date, you'll have to sign a contract with Concentra if you want to utilize their services. And there is a cost associated with it. It's not free. Certainly, if you do it yourself, it's probably more cost effective to do your own fit testing. The question is, how do you do the medical evaluations and the training, because those are also a part of the fit testing or the initial fit testing process. So you've got to kind of factor that in. With the Concentra contract, it's $60, and they do the medical eval and the training and the fit testing all in one kind of service. Anyways, you can continue to use that if you want, but it does go away in a few weeks here. And so we wanted to make you aware of that. All right, in terms of the big one here, AFL 20-22.8, so this is version 9 of the guidance for limiting the transmission of COVID-19 in long-term care facilities. Essentially, this is the visitation AFL for skilled nursing facilities. And I want to make that clear that this is for SNFs only. The folks for intermediate care facilities have a separate AFL that, you know, guides them through very similar requirements as this. And so I'm just going to go over the general guidance at first, and this general guidance is going to apply to anybody that enters the building, regardless of their vaccination status. So we'll talk about those kind of overarching things, and then we'll dive into each salient point of the AFL as we work through it. So each visitor is screened for fever and symptoms of COVID and any close contact with a confirmed case. And there is a definition in the AFL of what a close contact of a confirmed case is. It's a cumulative total of 15 minutes over a 24-hour period, I believe, within the 6-foot bubble. The thing that has, it's been pretty standard that close contact definition has been in place for a while. So I don't think that has changed materially. But if any of those things, if the visitor, regardless of what type of visitor it is, regardless of whether they've been vaccinated, if they have a fever, if they have symptoms consistent with COVID, or if they have a confirmed close contact or a close contact with a confirmed case, you need to restrict access to their ability to visit until they meet the definitions for removal from, they're either, you know, have been symptom free for 10 days or they have a negative test, you know, things like that. So we're going to be required to be the, you know, the kind of monitor of that. We need to make sure, and certainly the surveyors are going to ask to see your process to make sure that you're doing the screening, you're monitor, or you're taking the fever or temperatures, and you're asking questions if they've been in close contact with anybody. All visitors are going to wear a mask throughout the facility, and there's a little star there. There's obviously exceptions to that in the AFL, and we'll cover that. But just think, before they enter the facility, they're going to keep that that source control on, or tight-fitting face mask, or well-fitting face mask, I think is the way they term it. But that link there tells you kind of the definition of what the masking requirement is for them, and perform hand hygiene upon entry. Now, if they are required to wear PPE as a part of that visit, meaning they're going to be in a red or a yellow zone, and there's exceptions for visitation in each one of those zones. We'll cover that in a second. But you're going to provide them instructions on how to don and doff that PPE and how to correctly wear it, and that is required in the AFL. So we want to point out that CDPH was not, they were not ambiguous in this. The requirement is going to be that you provide the PPE and you give them instructions on how to put it on. While in the facility, this applies to every visitor, they're going to physically distance from all others throughout the facility. And so that means that when a visitor comes into the facility, they're going to go directly to the area that they're planning on having their visit, whether it be in the resident room, indoor communal space, or an outdoor space. They're going to go directly to that area. They're not going to get within 6 feet of any staff or other residents, only with those within their family and those they're there to visit. Visitors who are unable or unwilling to comply with the core principles should be asked to leave. Now, I realize it's extraordinarily difficult to monitor in-room visitation, but in these outdoor settings, in the large communal spaces, if you're going to do it that way, then definitely you need to have some kind of monitoring process to be able to make sure that each, you know, because when we're doing it in large communal spaces, there's more than just the you know, infection prevention between the resident and their family member. It's between other households. So you're going to have to make sure that distancing is observed with folks outside of their household if you're using a large indoor communal space. And it goes on to state that facilities should limit the number of total visitors per resident and total visitors based on the facility size. So this is kind of your ability to work within your limitations of your physical plant and your operations to schedule these visits. But when we do the scheduling the visits, we want to make sure that there's equity, that every resident that wants to visit, that has the opportunity to is provided that opportunity. Here's a recommendation. This is not in the AFL, but there is a portion of the AFL that talks about, creating a listserv and sending information out to families. My suggestion is to develop in your information sheet, if you've not done this already, is what the expectations are of the visitors prior to them coming. Tell them they're going to be screened, they're going to be asked questions about their exposure, things like that. If they fail though, well, one, we want to tell them if they have a fever or symptoms of COVID, or if they have a close contact, don't come. Just stay home. We're not going to allow you in anyways. So if you have any of those things, please just call us and we'll reschedule the visit. That's the easiest way to do it. I think we want to be clear with their expectations of the visitor when they come, so that way when they get there, they're not surprised by you asking them to maintain physical distance from everybody else in the facility, even though outside of our facilities, it certainly doesn't look like, as you walk through stores and other places like that, it definitely looks different. So want to be clear with what the expectation is for all visitors as they enter the facility. All right, so for indoor, in-room, and large communal space visitation, it was very clear that CDPH said every green and yellow resident is allowed indoor, in-room visitation, regardless of whether they've been vaccinated or not. If the resident and their family members are both fully vaccinated, the visits may be conducted without masks or distancing, and they may touch, like hand holding, hugging, all that good stuff. Anybody that's partially vaccinated or unvaccinated on either side, meaning the resident or the family member, both then must keep their masks on and maintain that 6-foot distance throughout the visit. If the visit is in the resident room, it should be obviously provided without the roommate present, regardless of the other roommate's vaccination status, or in a separate indoor space. If, let's say the roommate's bedbound, and well, certainly if they're not vaccinated, I definitely would not put another non-vaccinated visitor in with them. But certainly we want to, if that's the case, you want to try to incorporate some kind of indoor space where that person could visit without putting the other roommate at risk. Any visitor that's going to be visiting with somebody in the yellow zone needs to be provided appropriate PPE for that zone. So that's full, that's a respirator, that's eye protection, that's gloves and a gown, as well as instructions on how to don and doff, and instructions on how to obtain a seal on the respirator. On that link where it says instructions there, I've linked to a YouTube video for the CDC on the donning and doffing instructions for a full set of PPE. So it's a 4.5-minute video that shows, gloves, gowns, mask, and eye protection. So if in your communication with families, you might want to say, hey, here's a great video. If you know they're coming to a yellow zone resident, here's a great video that you can watch prior to your arrival that will help you understand how to don and doff this personal protective equipment appropriately. If you have the capacity to set up a monitor or something like that and have visitors come 10 minutes before they visit, have them do the screening, go through all the questions, get kind of processed in, and then watch a 5-minute video on how to do the PPE. You could do that. I know that would be fairly difficult to do. If your IP is comfortable and they're not overwhelmed with other kind of work, maybe, or the DSD or somebody else could instruct those folks. You don't have to use a video, but by using a video and a video done by the CDC, we maintain consistency with the instructions given to the visitors. And that way, if there's a failure, it's not as a result of what they've been instructed to do, because what they've been instructed to do is what everybody's instructed to do. So it just kind of, there's an added layer of protection for you by pointing to a government institution that has recorded this video on how to do this appropriately. Any visitation in a large communal indoor space, such as a lobby, cafeteria, activity room, you're going to have 6-foot distancing between these visitor-resident groups. So even though a visitor and a resident may be unmasked and hand holding and within 6-foot distance if they're both vaccinated in that communal space, that group cannot get within 6 feet of other groups, regardless of what the vaccination status is of any of the individual groups. So this is same as in room for fully vaccinated. So if the resident and the resident family members are both fully vaccinated, it allows for the removal of masks and does not require the 6-foot physical distancing, and touch may be, physical touch is allowed. Like I said, they must still be separated from other parties during the visit, and there are exceptions to red zone visits, compassionate care, legal matters, P&A programs, disability rights. There's a number of elements within, it's not just compassionate care. And we'll talk about other folks that come in that can go into any of the zones. Folks like ombudsmen or surveyors, or obviously healthcare workers can go into red zones, and they're not subject to these same kind of restrictions because they have other requirements that are in place that kind of do the same thing. All right, in terms of outdoor or large indoor communal space visitation, most of you guys that are doing outdoor visitation, the outdoor visitation as it stands does not look much different. The only difference would be is if folks are fully vaccinated, then same thing. Both the folks can take off their masks. They don't have to do physical distancing, and they may touch each other. They're still going to have to wear the mask getting to wherever they're going to visit, and they're going to have to wear wear the mask as they leave from their visit, especially if they have to egress or ingress through the building itself. If they're outside and they walk from an outside area to the visiting area, the AFL is not specific about when they should wear that source control, but let's just say from the time they check in to the time that they get to their visitation area, even if it's outside, they should be wearing source control. Just to be on the safe side, I wouldn't want a surveyor to watch folks walking around without masks on outside of your building and then drawing some conclusion that you didn't do this correctly. So I would just say after they check in, make sure that they wear source control till they get to the spot where they're going to visit. And then once there, whether they keep the mask on is going to be whether they and their loved one have been vaccinated or fully vaccinated, I should say. Staff should monitor these group visitation areas for IPC adherence. Make sure, if folks have kids and things like that, depending on the age of the kids, I have a young one, and so my son's great at wearing a mask. He gets really weirded out when I ask him to take his mask off. So I think kids are probably better than we think they are. But if you have really, really little ones, then it's going to be hard to keep control of those folks. So if you're monitoring that situation, just approach a parent and say, hey, can you keep them in the 6-foot radius? Here's a chair for them. Make sure that they have a way to continue the visit without putting other folks at risk. We'll need to continue to provide alternatives for those that can't visit in person. So just because we're open for visitation, if you have residents that have loved ones in other parts of the country that have utilized these kind of technology solutions to visit their loved ones, we want to highly encourage you to continue that, because those folks will not have, even though that we're open back up for visitation, those folks will not have that ability to engage with their loved ones. And so we want to continue to offer those alternatives for those that can't visit in person. Some of the other recommendations to keep, obviously we've all talked about having a dedicated staff contact or staff contacts to be kind of scheduled a visitation, have a dedicated phone line if you can, or some other kind of message board where people can get information, latest information on not just visitation policies, but what's going on in the facility, as well as a listserv to communicate those kind of expectations when they come for a visit or things like that. All right, so for communal dining and group activities, fully vaccinated residents who are not in isolation or quarantine, meaning, these are our green zone folks, they may eat in the same room without practicing physical distancing or wearing masks. Obviously, it's pretty difficult to wear a mask while you eat, but they don't have to do the physical distancing. So that means if you had a cohort of fully vaccinated residents, you could, conceivably have them all sitting at a group table now, provided everybody is fully vaccinated. Where that changes is if any unvaccinated residents are in that communal space, source control will be required for all, obviously when they're not eating, and the unvaccinated resident should stay physically distanced from the other residents. It doesn't mean that now all of a sudden the vaccinated folks need to be physically distanced. It just means that they need to be physically distanced from the one or a multitude of unvaccinated folks, but they themselves can stay closer together. For fully vaccinated residents who are not in isolation and quarantine, they may participate in group and social activities together without face masks and physical distancing. It's the same scenario with the communal dining or as it is with the group activities. If any unvaccinated residents are present, source control for all, and the unvaccinated resident should stay physically distanced from other residents. If in the case where you can't ensure vaccination status for any person in that group, then all must follow the current infection prevention and control guidance. So that means that in a case where you can't ensure somebody's, these folks have been vaccinated, or if you have an activity where people are going to come and go, where you can't verify, the new people that are coming, they're going to come into that cohort essentially. If you can't verify the vaccination status for the entire duration of that activity, then all of the people participating in that activity should follow the current guidance. And that just means we're going to expect them to maintain that 6-foot distance and practice source control. You should obviously, any event that you do, it should be planned out in advance. That way you can verify the vaccination status of the participants, and you can kind of ensure that they can have that mask-free, socially, without the distancing, so that they can kind of get back to some normalcy. So I would, you think about doing cohorts of groups of residents that have been vaccinated for activities, or cohorts of groups of residents have been vaccinated for dining and things like that. I don't want to make the unvaccinated folks uncomfortable or feel like they're being left out. So we have to equally accommodate those folks. But for the folks that have been vaccinated, I think it's important that we kind of, engage with that normalcy and get folks back into that mindset. And I'm certain the residents are ready for that for sure. And if at any point you develop any positive cases, if you develop a positive case in a healthcare worker or a resident, and this, you should confer with your local health department on modifications to any of these group or communal dining activities. If you're in an outbreak, we don't want to continue doing this, especially if you have low vaccination rates between either staff or residents, but particularly residents. We definitely don't want to continue doing that. So if you begin doing response testing, you determine you discovered a positive case in a staff or a resident, I think most health departments would continue to recommend modifying those things until you've cleared the outbreak and gone back to kind of the screening testing or requirements. So definitely want to confer with your health department on any modifications based on outbreak or response testing. All right, so they did go on it, and this was a really big question of ours, was residents who leave and return to the facility, how would they be treated? Residents and their families should be advised of the risks, obviously, and steps to limit the risk. The risk is definitely different if they're not vaccinated versus if they are vaccinated. We want to encourage them to adhere to whatever the recommended infection prevention measures are. If they're going to go to like a family member's home, their CDC guidance on kind of what you should do when you're visiting others based on your vaccination status. That's linked where it says CDC guidance. Any resident that leaves the facility that has close contact with a confirmed case will need to be quarantined and tested immediately. So if they come back and they go, you know, my cousin so-and-so went and got a COVID test, turns out they're positive, that, you know, that kind of confirm, and you go, oh, I was in the same house with that person, and I think I was with them for more than 15 minutes combined over the course of that 24-hour period. They're definitely a confirmed case, or a confirmed close contact. We want to quarantine them and test them immediately. If the test is negative, test again between day 5 and day 7, regardless of whether they've been vaccinated or not. Now, any resident who leaves for less than 24 hours, meaning they go out on an outing with their family, they go to a restaurant, they go to a barbecue, a family reunion, you know, it doesn't really matter what the reason is if they go out to a hospital. Anything less than 24 hours, there is no need to quarantine them upon return. Now, this is only for those folks that have been vaccinated, or I'm sorry, this does not apply to those, does not apply for regardless of vaccination status. I apologize. So I want to make that clear. It does not, it's not, has nothing to do with the vaccination status. But any resident who leaves for greater than 24 hours must be managed like a new admit. For a new admit, if the new admit is fully vaccinated, they don't need to quarantine or test upon return. They go directly into the green zone. And that includes folks that maybe they go to the hospital for you know, 3 or 4 days and they come back. If they were fully vaccinated, then they do not need to quarantine and they do not need to be tested upon return. Obviously, that there's a little caveat there, as I could hear Dr. Epson in the back of my head talking to me and saying, but if there's an outbreak at that facility in which they're coming from, then we would need to monitor, or we would need to treat them as if they were exposed. And I think that's true, but given the level of community community transmission is pretty darn low now, the likelihood of you running into that scenario is minimal, but it could happen. So be tuned into what's happening at the hospitals and what you deal with. You know, if you talk to, you know, I don't know if you're communicating with those folks, but asking them if they're having transmission within their facility, it's not likely they're going to cop to having outbreaks, but they may tell you, hey, listen, you're definitely going to want to test these folks when they get to your facility. My hope is that they would be honest about that, but certainly that's not a guarantee. But you should at least confer with them to make sure that's not the case. Everybody else that's either partially vaccinated or unvaccinated will need to be quarantined for 14 days, obviously tested as they enter and tested prior to their return to the green zone after that 14 days. So you can see that part hasn't changed much. That's the same. I want to make it clear, though, if they leave for 24 hours, regardless of their vaccination status, there's no quarantine and no testing requirement when they come back. The only time we would do that is if in that less than 24-hour visit, they had close contact with a confirmed case. Then we're going to put them into quarantine and test them immediately. Sorry there, I kind of flubbed that last part there. So, all right, so non-essential personnel and contractors are allowed now in the facility. They should be subject to the same testing and universal face mask requirements as all your staff. If they're going to come into the facility, you know, frequently like the staff, you can consider using those the Abbott Buy Next Now cards. Those are effective if you use them frequently enough. If they're coming for, if it's a contractor that's coming for one service, sprinkler contractor or something like that, you'd want to say, hey, can you get a PCR test prior to coming in, so that we can document that. For other types of contractors like beauticians, manicurists, pedicurists, folks that would come in and do that kind of personalized service, for those folks, we still want to include them in the testing pool, make sure that they have wear a face mask while they're in the building, including while they're doing their work, whatever that work may be. We're going to encourage any of these contractors who are entering the building, if they have not got vaccinated, please, we're going to encourage, especially if they're going to continue to come in, or if they frequently go into skilled nursing facilities or any kind of congregate setting, you definitely want to get vaccinated. It's even more important for us as workers in our industry than it is for folks in the general public. So we want to encourage them to get vaccinated if they've not been. If they need a connection with how to get vaccinated, connect them with the local health department or any of your hospital providers. If you are a vaccine provider, let's say you're in Los Angeles County, you may even offer to vaccinate them yourselves. You certainly can do that if you've gone through the process to do the MyCA Vax and PrepMod and CARE and all that good stuff. If you're set up to do the vaccinations yourself, you can do it for those folks. And we should, it is encouraged to provide these services outdoors if possible. And that may not be feasible for some of them, especially, like a hairdresser or salon, that kind of service. They need access to power and things like that, mirrors and lighting, although outside lighting is pretty good. I don't know if that's feasible, but if you are going to do it indoors, we want to do it indoors with good ventilation. There's a fairly good guide from CDPH that talks about kind of best practices for increasing ventilation in spaces, and if you have like a salon in your building, if you've not looked at kind of what the airflow looks like through that. One thing, we don't want residents congregating in that area, and so if that salon kind of has like a waiting area, we don't want to utilize that. It's just just a contractor with the resident. It's going to, if they're doing hair, it's impossible to maintain 6 foot distance, but we want a well-fitted face mask or tight sealing face mask by that contractor while they're doing that work. But we definitely don't want other residents within a 6 foot bubble of that person until they actually need to be. All right. Exceptions to the visitation restrictions, obviously healthcare workers, employees, consultants, contractors, volunteers, caregivers, anybody who provides care and services to residents on behalf of the facility are considered healthcare workers for the subject of this AFL, including those nurse aid training programs, any academic institutions. Those are all folks that are considered healthcare workers per this AFL. Then there's surveyors, ombudsmen, students, legal matters, PA programs, disability rights, things like if you have a deaf person and they need sign assistance and you don't have anybody to sign and you need to communicate with the resident, those visitors would be that's a great example. Those folks would be allowed to visit regardless of and now these folks can go anywhere in the building, meaning they can go in yellow, red, green, anywhere in the building, wherever they need to go. But when they go to those portions of the building, they're still going to have to follow all of the same requirements. So if that's an ombudsman that's going to go into a red room, that ombudsman needs to wear full PPE. If they're going to go in a yellow room, same kind of deal. If they're interviewing outside of those rooms, it's a little bit different. But if they're going into the actual zones, they need to follow it just like the healthcare workers do. Now, if the healthcare workers are not required to wear a respirator while in the hallway, don't tell the surveyors that they got to put on a respirator just because they're walking down the hallway. It should be consistent with what the requirements are. Anyways, each of these folks is going to be subject to symptom checks or symptom screening, fever checks, You're going to be required to wear that face mask and perform hand hygiene prior to entry into the building, and frequently throughout their visit. We want to encourage them to do that. All right, so that kind of covers the visitation. Not huge changes, but there were definitely some changes. I want to cover the NHSN reporting because this is a bipolar opposite of what we told you last week. And I promise you, we did not, we held that information for a couple weeks. When we told you guys to start reporting to CMS or to NHSN directly, that was because we were told that specifically by CDPH, that they would not be adding the vaccine and therapeutics questions to the daily survey. So, well, knowing that, we made the decision to tell you guys, look, the fines are going to be your responsibility, not CDPH's, and you're going to get hit with the fines if you're not reporting this information. So if CDPH is going to drag their feet on incorporating this until the last minute, we're going to give you information on how to not cross or get cited by CMS for not reporting to NHSN. So we gave you information that said, forget reporting in the 1, 2, 3 surveys. CDPH is not going to include it. And of course, on Wednesday or Tuesday, whenever Cassie broke the news to folks, that was the first I had heard of it, and she had not told that to any of us at CAF prior to that. So they changed their direction. Why that is, I don't know. But when we had talked to them, they said, no, we're not going to add those to the survey. We're going to have them do the NHSN. And not only that, we're thinking about rolling back the survey. Well, both of those things are not true. For the time being, we're still going to have to do the daily survey. And in those daily surveys, they're going to begin asking the questions on the vaccine reporting. My hope is on Wednesday, I've asked the department to present on the HSAG webinar where they talk about, if you convert your rights, just show us screenshots of what the daily survey is going to look like. What are the new questions? When do we got to answer them on? What day do we have to have this submitted by? My hope is to have that information presented to you in an educational setting on Wednesday, as well as we do know an AFL or some kind of memo is going to be sent out explaining what the changes to the reporting are going to be. They are going to change the dates to align with CMS, so we don't have to do this. But I've talked to a number of facilities that have said that they have to manually go in and verify that the information that they've inputted to CDPH is rolling over to NHSN correctly. Because ultimately, we're responsible for the information that NHSN gets. If it's incorrect, it's not CDPH's fault, it's our fault. And we have the opportunity to correct those, but you have to go in and verify that information independently. And it stinks and it's time consuming. I wish I had a better answer for you. My hope is really this reporting will get drawn down. I keep saying it's going to come soon, but it's not soon enough, I realize, but I do think it's going to change. If on Monday you go into your survey and you do not see these new questions added that they said that are going to be on the survey on Monday, we need to know about it. Let us know so that we can address that, because we'll have to talk to CMS about postponing the date in which they start issuing citations and financial penalties, because that date is right around the corner. That's only a week away from now, or 9 days from now. It's not very far. So we want to make sure that CDPH is going to be able to do this, so it doesn't put us at risk. All right, in terms of the Cal OSHA emergency standards, late last night, Cal OSHA released their proposed readoption of the emergency standards. They will be extended until July 31st. I've included the handouts in the handouts for today, both the proposed text and the readoption text. One of them has kind of lined out items that shows the new additions to the emergency route, because there were some changes to that. And as well as the entire document without showing the previous changes. This is a little easier to read and doesn't have all the draft through the middle of it. They did punt on the requirement to provide N95s. I didn't really talk about this much, but in the emergency hearings that Cal OSHA had, many of the labor unions had asked that all employers, not us, not just us, every employer in the state would be required to provide an N95 respirator to any of their unvaccinated staff, provided the staff wanted to use it. It wouldn't be required that they use it, but you would be required to provide that to them. And that would apply to every indoor workplace in the state. And that's obviously that's a lot. So rather than provide that guidance, they essentially divided it up into two sections. If you have the ability to, have physical distancing and, develop kind of a workplace that incorporates that physical distancing, then you would not have to be subject to providing the N95s. It's kind of an either or. In our case, it definitely, our care staff is all going to be under the ATD standard. This does not apply to the folks in the ATD standard. But if you have, let's say, well, if you're a CCRC, obviously this is going to apply to your AL side. But if you're a SNF and you have maybe your, maybe your admissions coordinator is not in your ATD plan, or some of those other, kind of administrative functions that you've not put into that, those folks would then, if they're not in your ATD plan, they're going to be subject to this requirement. So it's a lot. It's a lot. It really follows mostly what we're already doing, and it really highlights all the stuff that you guys have to do as not just employers, but as providers of healthcare, because it's what we do in order to protect the residents. But when you see it listed out like that for other employers, they're looking at this and just going, "Oh my goodness, it's nuts." It's 26 pages, single spaced, really dense stuff. So there's lots of detailed requirements. If if you're on the AL side, gosh, I really highly recommend perusing that. There's a lot of things that you're going to be required to do. All right, the CDC, we talked about this last week in the questions. We had a question about the travel recommendations, and I had recommended that you should, as a part of your policies on when your employees return to work, you should have this as a, kind of a barometer of what you should do in terms of infection prevention and control requirements once they come back. So now if you have a staff member that travels internationally, there's a map on the CDC website that has a tier category 1 through 4 of what the recommendations are based on the country in which they're returning from. Almost every country in the world is in a tier 4 category. There are some exceptions: China, Australia, some places maybe folks would go on vacation, but lots of the other places, everywhere tropical, sunny and warm, they're all in the red. All of Europe, all of Central and South America, it's just assume that if they're going out of the country, they're probably going to be returning from a tier 4 country, and then they would be required to do the following things. So one, the employee, before they even get to the US, wherever they're coming from, they're going to have to test and show a negative test before they're allowed to come back to the US. So that's their responsibility. Obviously, you don't have to do that. But once they come back, they're going to have to test 3 to 5 days after arrival and self-monitor for symptoms if they've been vaccinated. If they've not been vaccinated or they're only partially vaccinated, they need to test 3 to 5 days after arrival and self-quarantine for 7 to 14 days, depending on the job scope. And that's a little bit different because it added this language in that said and I added the job scope part. In the guidance, it says 14 days if you're around folks that are likely to have adverse reactions to COVID. I forget the exact terminology, but it essentially means that anybody that works in a SNF would be subject to this 14-day requirement, because if you work in a SNF, everybody in that building is subject to, well, every resident is adverse outcomes. So we're definitely going to self-quarantine folks that come back from those tier 14 or tier 4 countries for 14 days if they were either partially vaccinated or unvaccinated. And the link to that is under the international travel during COVID-19. If you scroll down, you'll see that information for the unvaccinated, and this has changed just slightly from the last time we updated you. All right, that's the end of my updates. I will say, as a rare spot of good news, there was a really potentially costly piece of legislation, AB 650, that would have expanded the requirement for COVID hero pay. It would have just been a really difficult thing for us. We had costed out at over $1 million per facility, over $1 billion to our industry just in the state. And yesterday afternoon, we got news that the legislation was pulled. We don't know if it's going to come back or if it comes back in some other method, but the good news is that is no longer on the table. So that's great. All right, I'm going to hop to questions, and I'll see if I can get through them. There's a bunch today. Obviously, I kind of figured as much. We'll try to get through as much of these today as we can. Has CAF heard from LA County DPH about updated visitation guidelines? No, we have not. And certainly LA, amongst a few others, has marched to the beat of their own drummer. Not to say that it's vastly different than what CDPH has done, but there has always been a little bit of nuanced differences. In the LA Department of Public Health, if you go onto their website for visitation, it links directly to the 2022 AFL, and it tells us to follow that. And then where it differs, it says it directly below that. I don't know, once they get a hold of this, because this just came out, a very short period of time. It will take them probably a day or two, I guess, to address those issues. Until then, I would actually probably reach out to ACDC and ask them and say, have you guys had a chance to review this? Can we begin to operationalize these changes? My hope is, they'll send out an LA HON or a Los Angeles Health Alert that talks about the differences between what CDPH is in the AFL and what their individual county requirements are that are different. So stay tuned for that. I realize it will change. For LA County, I do expect there may be changes. We know the changes for testing will probably, they'll continue to try to monitor those unvaccinated residents even after CDPH changes the testing requirement. So I expect they will maybe have some minor differences. Next question, is it still required or preferred to do screening a person, or does it seem to move to an automated kiosk? Whatever is, the answers to the questions are the answers to the questions. And if somebody's going to be untruthful, they're going to be untruthful to somebody in person or an automated machine. I don't know that it's going to make any difference. As long as the automated kiosk can perform the service, or if it's an app or it's some kind of technology that reduces or eliminates the requirement to have a person actually manually do that function, I'm all for that. I look at that person's time that it takes as a resource, and that resource I need doing other things. And whether it's assisting with scheduling visits, or it's responding to family members' calls, or there's a billion other things I could have that person do. And it seems silly if we could have a computer or an automated service do the exact same thing. So if you can find it and it works equivalently, by all means, I think it's a great use of that resource. What is the guideline of fully vaccinated staff member that just returned from Puerto Rico? And I mentioned the tropical thing, but I actually think Puerto Rico might be one of those countries that's not in the tier 4. Let me, let me see if if I can do this. I'm gonna just while I've got, I think I've got it up on my thing. So I'll just pull up Puerto Rico if you give me 2 seconds here. And she's exhibiting no symptoms. Obviously, we want to screen and those folks and make sure they weren't exposed while they're there. Sorry, the map is giant and Puerto Rico's small. Let's see here. Oh, no, I think Puerto Rico's in the tier 4 as well. So that would mean they would be, yes, Puerto Rico is in tier 4. Sorry, definitely for those folks. So that same scenario I gave where that person would, if they're not vaccinated, they would need to stay out of work for 14 days. If they are vaccinated, obviously, and come right back. So. All right, staff should monitor group visitation areas for IPC adherence. Yes, is it appropriate to have an employee inside keeping an eye on the outdoor visit from the desk, or does an employee have to physically be standing outside during the visit? It's not spelled out in the AFL, and I think as long as it's written into your visitation plan, I would put it in writing and say, we've reviewed how well somebody can view compliance with the IPC requirements from this location, and this is or maybe that location allows you to have eyes on 2 separate visiting areas. Whatever the case is, if you put it in writing and it's feasible and it works, then sure. There's nothing there that says you couldn't do that. It's really more of you saying, yes, I can maintain adherence and observe these areas by doing it this way. I put it in writing. This is my plan. I think that's is probably going to be appropriate. And certainly standing outside it just gives a bad impression. I don't know, from a visual standpoint, from a visitor, you think, I'm not a child. I can do this. You tell me what to do. I'm going to do what I need to do in order to protect my loved one. I'm gonna, I think so. For some people, they might be turned off by having somebody oversee the visit. So if you can do it in a non-obvious way that, it kind of gives the ability that the resident and their family member are having this private kind of moment, I think that's what we want to do. We don't want to intrude on that if we can help it. And if we can find ways that are that we can view that without being obtrusive, then all the better, I think. So for fully vaccinated residents, can they be out in a hallway without a mask? No, since in a hallway, we couldn't really guarantee, the vaccination status of anybody that's going to pass through that hallway. I think as they move through common areas and things like that, the recommendations is still going to be source control, regardless of the vaccination status. Next question, are we to screen visitors regardless of vaccination status with POC and weekly testing? You certainly can offer the visitors, testing, and as a kind of an added layer of protection, especially for those visitors that are not vaccinated. Let me expand this question because maybe it went past that. So. What is the guideline? Oh, okay. Yes. Yes, you're to screen. Sorry, the question was, are we to screen visitors regardless of vaccine status with POC or weekly PCR? So you don't have to test the visitors. That was not in the AFL, but you could, if you had a CLIA waiver, you could use, and you have the Abbott Buy Next Now cards. You could utilize that as an added layer of protection. Traditionally, that's not really what they're utilized for. They're usually most effective when they're used for symptomatic people to be able to determine if they're positive. You could, especially if they're unvaccinated, you could say, hey, but you can't make it a requirement. That's the whole point. We want to open up this the kind of visitor restrictions. You just can't say, hey, listen, you can't come in unless you've tested. You can't make it a requirement, but you could offer it as an added added benefit. Will one of the upcoming AFLs go over staff meetings if fully vaccinated, being the meeting without masking or social distancing? Yeah, that's a great question. I think that AFL will come in the form of the revision of the requirements for PPE. I don't think that's going to change a whole lot in terms of the source control being required. You know, as you walk throughout the facility, I see that staying for a while. But I do see the ability to have these, you know, meetings if you know all of the staff are fully vaccinated. It makes no sense to, you know, to continue to do that. You know, if we know secondary transmission is, you know, highly unlikely, then it just seems overkill, to be honest. So, but I think that will come in the form of a revision of what, you know, that kind of overarching PPE requirement and the mitigation plan. And I think it's 53. I think that as well as the testing, I think those are going to be the next to kind of be changed. In terms of do visitors visiting yellow zone residents and outdoor visitation also need to wear N95s or full PPE, or is a surgical mask okay for outdoor setting? You know, that's a great question. I think if they're going to be, you know, obviously within a 6-foot bubble of that that resident, I would say yes, but I don't think that's allowed in the yellow zone. So to answer your question, I think it would be okay, but that's a, you know, that's a great question. I'm going to pitch that to Dr. Epson. I think by the letter of the law, that even us as healthcare workers, if we were farther than 6 feet away from a resident that was a yellow zone resident, we would not be required to wear a respirator. So therefore, I'm not sure that the visitor would be required to wear a respirator. But I'm just guessing here, and I think that's probably the answer. But Brad, I don't know if you participate on the HSAG calls on Wednesdays or the conference calls on Thursdays, but I'll pitch it to Dr. Epson because I think it's a great question, and it's probably one that will frequently come up. Do visitors visiting green zone residents still need to wear eye protection? No. So now I will say there are some counties that are maybe still in those moderate to sustained transmission, but I think most of the counties are out of that. And if their county is not that, then you're not required to wear the face shield. I don't know where your facility is, but if you tell me what county you're in, I can find you the exact answer. But for the most part, most of the counties, you're not going to be required to do that. Do all unvaccinated staff have to wear an N95, even if they work in the green zone? No. But in the Cal OSHA ETA standards for non-skilled nursing facilities, meaning you have an AL, you have some other type of provider that's not function that's not subject to the aerosol transmittable disease standard, then that may be a requirement for you to offer that for voluntary use of your employees. But that's only if you cannot meet the other 6-foot distancing requirements. It's more than just 6-foot distancing, and there are workarounds to that. It's I don't know how they write these things, but it's really complex when you look at the proposed regulations for what is allowed if you're not going to offer them an N95. If you're a SNF, if you've written everybody into your ATD program, you're not going to have to worry about that. But if you got other folks, then definitely you will. Guidance for vaccinated staff members. If we are all vaccinated, do we still need to have social distancing in break rooms? Well, my personal opinion is I think no, but as the guidance has gone, that has not changed. It was not addressed. So I do anticipate it will be addressed shortly, as well as what the residents should do in the case. Another thing they did not mention was, what if a staff member is unvaccinated and all the residents are vaccinated and they want to take their masks off and be close together? I think that being close together is fine, but it did not address whether they would be required to wear source control because they had a staff member who was unvaccinated. I'm sure that question is going to come up. I believe the answer from Dr. Epson is going to be, provided that the employee is tested and they're wearing source control, that's okay. But I don't know that for sure. They didn't address it specifically, and I know folks will have questions about that. And it's a similar kind of thing for the staff in the break rooms. It would seem that it would be allowable. My hope is we can get that clarified when they redo the requirements on PPE and the mitigation plan changes. Pasadena has adopted the AFL with no changes. Okay, that's great. So also, if you're in LA County, but in the city of Los Angeles or Pasadena, obviously they have their own requirements that will differ from LA County Department of Public Health requirements. They've traditionally followed along with LA, so or been fairly close to LA, so it hasn't been too big of a deal. But if you're in Long Beach, definitely confirm with them or any other health department to make sure that there's no discrepancy between the AFL and what they want to see inside your buildings. Is there any guidance to regards to testing frequency for vaccinated staff? I'll keep going for 2 more minutes, guys. I want to get to this because this is important. I believe on Monday we should see an updated AFL that prescribes the testing frequency for vaccinated staff going away, meaning they will not be included in the screening testing pool at all. Now, if you have an outbreak, they're going to be pulled back in to do response testing, but they're going to be allowed to be removed. I anticipate that's going to come on Monday. I keep saying this, but Cassie did say that this would come out Monday. We've looked at the draft of this, so I don't think there's anything controversial in it. It keeps much of the same requirements, weekly testing of non-vaccinated staff. Obviously, if you're in a county that has its own more restrictive requirement, Los Angeles, I'm talking to you, you'll still have to do whatever they choose up and above this requirement. But I think they'll probably follow suit with this. They'll just say you need to keep testing a pool of your unvaccinated residents. If we report vaccinations to NHSN and we answer CDPH vaccination questions, will they be double counted? I don't know yet. I guess we're gonna learn or trial by error here, I don't know. I don't think they will be. I think if you're going to answer the questions on the 1, 2, 3 survey, which is fine, it makes it easier for you to do it. Well, I assume it makes it easier for you to do just one format. No, if you do it, and you go check a couple days later, if the information is not correct, you can go in and update that information, and that information will backflow to CDPH to update it to the correct information. So you can go back in on the NHSN side and correct what CDPH, well, you have to go in and correct what CDPH has done. Hundreds of facilities have told us that they've had to do that pretty frequently. So you'll probably continue to have to do that. I don't know that they'll be double counted. I assume that the CDPH data is going to go to NHSN, and then if it's incorrect, we'll add to it, and then it will backflow that information to CDPH to update it with the correct information. I don't know if that's the case, but I'll ask Patty if she can comment on that next week, and certainly we can ask Rose Chen on the HSAG webinar. She's really good with the NHSN stuff, so I'll pitch that question to her. All right, guys, sadly I've got a few more questions here that have to do with travel and testing and things like that. Hopefully I've answered those questions in previous answers. If not, I'm going to take a look at the remaining questions and see if I can't address them on the next format we have. If I can bring it to the HSAG webinar or the conference call on Thursday, I will do that. If not, I'll address all the questions I wasn't able to get to next Friday on this webinar. So I hope you guys have a wonderful afternoon. Have a great weekend. Expect next week we will be talking about testing changes and things like that. So hopefully everybody takes care. Bye-bye. Have a great weekend. Oh, and thanks, Summer and Jamie. You guys do great jobs. Thanks. Bye-bye.
Thanks, Jason. Bye.